Welcome, everyone. Thank you for taking time to join us for this webinar. My name is Janet Heischetter, and it's my honor to serve as the Executive Director of the Dystonia Medical Research Foundation, or the DMRF. I'm pleased to welcome you all to this webinar on the important topic of the caregiver journey, and happy to serve as the moderator for this program. Before we get started, I have just a few announcements. In order to keep the background noise to a minimum, and because of the number of participants, everyone will be muted except for our speaker. But your questions are a really important part of this program, and we encourage you to use the Q&A function on the bottom of your Zoom screen to send us your questions as you think of them so you won't forget them. And we'll do our best to address as many questions as we can in the time that we have allotted for this program. I want to thank everyone who sent us questions in advance. We'll get to as many of those as well. Thank you, special thank you to our support leaders, many of whom are joining us for this program. Thank you for being here, and thank you for your ongoing efforts to support those who are affected by dystonia, including their caregivers, an important part of the work that you do. I also want to thank Ipsen Biopharmaceuticals for their support of this program and other educational programs that the DMRF does. Please know that we are recording this program, and it'll be posted to our YouTube channel as soon as it's ready to go. And we will send everyone who registered for the program an email so that you can view it again or forward it to others you think will benefit from the program. So now on to the reason that we're all here. Caregivers are an important part of our healthcare system. Caregivers make sure that those who we're caring for are compliant with their treatment plans. They observe how their loved ones are doing and report those observations to the nurses and physicians who care for our loved ones. But oftentimes they neglect or overlook their own needs. We are delighted to present this program that's really going to focus on the caregiver journey and to have as our speaker Dr. Natalie Hellmers. Dr. Hellmers is a nurse practitioner at the Weill Cornell Parkinson's Disease and Movement Disorders Institute in New York City. She provides clinical evaluations and treatments for patients with movement disorders, including dystonia. Dr. Hellmers counsels the whole patient, reviews their medications, their exercise, and their diet routines with them. She is also the co-coordinator of the newly established supportive care clinic at Weill Cornell that supports a holistic approach to patients in all areas of health and their well-being. She attained her PhD in nursing research from New York University and has served as co-investigator on multiple clinical trials. Dr. Hellmers also moderates several support groups for patients with movement disorders, including dystonia, and their caregivers at Weill Cornell. We are so pleased to have her as our speaker for this program. Dr. Hellmers, welcome, and I'll turn the program over to you.
Thank you. Thank you so much, Janet, for the warm welcome, and thank you to the DMRF for having me here this evening. I'm delighted to be here with you all, and as was just said in the introduction, I am a nurse practitioner in movement disorders, so I do encounter patients with dystonia every day. I also spend a lot of time speaking with family members. Witnessing the ins and outs of caregiving and what they do inspired me to pursue studying caregivers and their role even further, which brings me to discuss with you all what I like to refer to as the caregiver journey. So as you can see on the slide, our agenda and kind of key points for the evening include going into a background on the family caregiver and the definition of what a caregiver is. We'll talk about dystonia in the context of caregiving. I will go over a literature review summary and discuss with you some of the gaps that I've discovered. I will share with you a summary of the work-life balance and family caregiver study that I was able to complete. And then toward the end, we'll go into some suggestions for caregivers that came out of my research and clinic experience and ongoing examination of life in literature. So full disclosure, My project was funded by the Pilots Projects Research Training Program as a part of the New York, New Jersey Education and Research Center through the National Institute for Occupational Safety and Health. And the funding mainly went toward statistical software and also to compensate the family caregivers who were so gracious with their time and volunteering their stories and their information. So let's begin with the background. Studying caregivers is important because the number of caregivers has really dramatically increased. We're looking at 43.5 million in about 2015, and we've gone upward to 53 million in 2020. And this is according to the Family Caregiver Alliance. So statistically, we estimate that about 1 in every 5 Americans has become a caregiver to some degree. Now, what is rather complicated is the identification of family caregivers and what they actually do to help their family member. It varies greatly, and it's not very well documented. And so, I hope, tonight as you listen to this program and look at these slides, you may reflect a little bit on your role and what brings you here tonight. Because perhaps you really truly are fulfilling a lot of caregiving supportive duties. Now, by definition, informal care is defined as unpaid care without having any formal training, right? Meaning, we're differentiating this from a formal caregiver who is a provider that's associated with formal service within a service system and has training, and they're usually paid. Now, definitions fluctuate over time. And actually, it was a year ago that we did receive, there was an executive order with a real strong federal push to give more recognition to family caregivers and advising that it's not, necessarily paid, unpaid, or even specifically unpaid to fit the definition of a caregiver, because there's recent policy that's trying to embrace the notion of, financially compensating family caregivers and possibly being reimbursed for their assistance. But again, in the context of what we're talking about tonight, right, we have the informal care, right? So somebody, family member, a relative, even a close friend, and then, other parts of the world use slightly different definitions. For example, the word care comes up in British literature. So rather than caregiver, they use care. And more recently, there are more and more organizations that like to use the word care partner. And perhaps that takes away maybe some of that stigma that goes along with caregiver, since not everybody identifies as a caregiver. And I would, add to that, even less formal, but also appropriate and even sometimes endearing is, simply referring to a family member as like a personal cheerleader, right? Somebody who attends visits, kind of tags along to procedures, sort of being that backup, extra set of hands, or even just, mental or social support. So now let's talk a little bit about dystonia and caregiving. So dystonia is really, it's a unique, rare condition. Dystonia exists as a primary diagnosis, right? It can be a condition in and of itself, and it also can coexist as a secondary diagnosis. Dystonia is very difficult to diagnose. There's a lot of, physical and mental wellness issues that get associated. It can cause pain. It can affect a person's mobility, their speech, their sleep, and numerous other non-motor symptoms, as well as overall quality of life. Management usually requires multiple treatments per year. A person has to maintain a variety of medications that can result in intense side effects. There are Botox injections that can be challenging to tolerate, and in some cases, dystonia can even lead to disability. And so while there's a wide range of dystonia symptoms, for some it's milder and a person's rather independent. In some cases, if a person has severe symptoms, they are medically refractory, meaning the medications don't work or the Botox injections don't work, sometimes surgical intervention is needed. When I first began my literature review, which probably dates back to about 2019, I did a really deep dive into the literature to see what was written about family caregivers and family caregivers in general. And I compared literature between, chronic neurological symptoms, between stroke, between dystonia, between Parkinson's, the ALS, the very numerous long-term issues, right, that don't have a cure and don't have an endpoint. And as I explored thousands of articles, I noticed that the focus mainly is on caregiver burden, burnout, stress, and strain. And overall, the Zarit Burden Interview is the widest used tool that's used to study the level of caregiver burden in general. Historically, in the literature, family caregivers tended to be female, and in some places, we see multi-generational families actually living together in the same home, thus alleviating the supportive care to only one person, but it's sort of spread out to many. However, this landscape is greatly changing. So some of the gaps in the literature, right? Number one, caregivers are not identified systematically, and this is not just national, but internationally. We see that scales or tools are limited. Using caregiver observation and expertise to help dystonia symptoms and diagnosis, though it's been talked about and discussed in the literature, it's still yet to be formally developed, right? But how interesting that, imagine if we had a scale or a tool that a family member could use and kind of, co-collaborate with the caring team, right? The team that's taking care of the person professionally, and try to help manage those symptoms. And, where my additional strong interest lies is the fact that, working roles of family caregivers are not systematically identified. I noticed that in multiple literature articles about caregivers, it's sort of like their work was an afterthought. They may be indicated if they were retired or if they're working, but not to the extent of their work or how perhaps juggling those roles was actually affecting them. And then finally, we can't ignore health policy. The Family Medical Leave Act, not everybody's eligible for. It depends how long you're working, depends on the work, and it depends on the state you live in, because there's a lot of variation state to state. So to spend a little bit of time talking about the study that I was able to complete, which I hope, you may perhaps recognize some familiar themes, maybe even some familiar situations. And, then toward the end, I'll talk to you about how it all came together. But the purpose of my study was to explore family caregiver perspectives on work-life balance. So as I said, I found that overall the literature has not really explored in depth that type of situation. And, I had a wonderful mentor who advised me to really pull data in various modalities, right? So I was able to do interviews, which was my qualitative aim, and to actually talk to family caregivers. And I then followed with a quantitative aim where I distributed surveys. And then for the third aim, I put everything together. And so the overall findings, I ended up getting 40 caregivers who volunteered for the study. And the people that they were taking care of in this particular study, they were all adults. They had Parkinson's, and dystonia was a secondary diagnosis for many. Some had other chronic conditions such as stroke, hypertension, diabetes, arthritis. And the level of independence varied. Some people were very independent. They didn't really need much help. It was more like, maybe a buddy system to come on clinic visits, but others needed a lot more help. Now, the study, it wasn't about the person with the condition. The study was about the person on the other side of it. So again, I was very curious as to see exactly who was joining. And in this case, the majority of participants were females, but sons and husbands also enrolled. The age range was wide. I had family caregivers who were 21 years old. I had family caregivers who were 75 years old. And the average overall, the mean average was about 57. Some were taking care of children, And those who were perhaps taking care of an adult and helping them with their dystonia condition or other various medical problems sometimes had to take care of young children. And that is actually identified as the sandwich generation, where a person may be actually kind of crunched between taking care of two separate generations. So the qualitative findings, right? So the interviews, I did a line by line analysis of every single interview. And one of the main themes that came out of this was that the working caregiver had work-life balance that was influenced by time, stress, and role behavior across both the working role and the family caregiving role. And a couple of slides down, I'm going to show you a little diagram that really portrays this well, this intersection of time, stress, and behavior. And I thought this quote was kind of a good example where this was a psychologist who was taking care of her spouse. She said, I go to work, but my office is 10 minutes away. In case I'm needed at home, I can quickly get back and forth. Sometimes the days are good, and sometimes there's a lot of pain and spasms. Now, here, I listed all of the barriers that I uncovered throughout the interviews, right? So when I asked the caregivers to describe their day-to-day life, what was their routine like, what was their work like, and then, really dug into those answers. And, the top barriers included physical stress. So in some instances, they actually had to physically help a person either get dressed or maneuver. In the case of emotional stress, there was a lot to unpack here, right? So there was frustration, there was fear, there was worry, there was anger. In many cases, the caregiver wanted to help the person with dystonia, but sometimes they didn't want that help, right? There was one example I remember a person was describing, they were going back and forth to visits and getting different medication. And then it turned out that the person wasn't even taking the medication. And ideally it was supposed to help the dystonia symptoms, but the person just gave them up. And that frustrated the caregiver really a whole lot because, to encourage and to force and to inspire. And then when the person actually isn't doing any of that, is hard. There's financial stress. There's a lot here. We could probably talk about financial stress for the entire hour. There were some people who basically said it was just financially less expensive if they did the caretaking themselves. So some people retired from work earlier, and some people just cut down their work hours if they couldn't get work accommodation. The role conflict was that juggling between the two places, and then there was access to care. So a lot of people said that they maybe were affiliated with movement disorder clinics, but sometimes they couldn't get a hold of the doctor. Sometimes they couldn't get an appointment. And sometimes they just felt like there was a lot of information that they just were not getting. Now, there were many facilitators, right? There's always a bright side. And when I, again, went through all the interviews, I discovered that disclosure was a frequent facilitator. So in other words, the caregiver basically said that they would, share kind of the background of the situation with their supervisor, with their coworkers. And it actually turned out to be a positive in most cases. Right? One person here on the quote above, said, we're going to support you. We're going to take blank names, health in consideration. Job flexibility was another facilitator. The chance to be able to take, an hour or two during the day away to join, whether it be a physical therapy appointment or a Botox appointment, and then be able to go back to work, without any repercussions. There was tangible support, so kind of being able to do ergonomic changes in the house, and then emotional support, which came from other people, usually family, sometimes friends, who offered to come over, offered to spend time, if maybe the person with dystonia wasn't feeling well or, whatnot, then at least having additional emotional support to help the caregiver out. Now, when I asked caregivers what they do to take care of themselves, many said that they did have workplace wellness program, but, and more than 50% said that they had them, but very few people were actually using them. Oftentimes they said that the time just wasn't sufficient. They would rather get home quickly, get home earlier. However, work was often seen as a form of self-care. For example, you could see the quote all the way on the right. One nurse who was taking care of her spouse said, "Up to now, what I was doing to take care of myself was to work. I went to work." And then solitary time was also frequently described as a form of self-care, the time to get away when nobody was asking you any questions. And I added this slide kind of to contrast what we just talked about, right? Because in the instance where a person says that work is the outlet, not everybody works. And, some caregivers who were not working, those who retired, those who stopped, they didn't have that outlet, right? And not everybody has various community outlets. Even living in a big city, you sometimes can feel very much alone and very much lonely. Chronic illness can lead to skipping out on social events, right? If somebody isn't feeling great, or maybe they're experiencing medication side effects, they're not going to be so likely to go and join a party or go to a family event. And often the person with dystonia may feel isolated or lonely, but also the person who's, living life with them, right? Because again, it's like if one person's skipping out, chances are the other relative is skipping out too. So here, if I can draw your attention to this slide, is the quantitative aim findings, meaning these were the surveys that I had distributed to the caregivers. I asked them about their work-life balance to score it within the special work-life balance survey score. And then the other surveys scored their level of stress, well-being, quality of life, and also their sense of caregiver burden. And what I did was I correlated the scores to see which ones were statistically significant. And interestingly, so part of the job content questionnaire, there's something called decision latitude, which is job control. It's the sense of a person being able to kind of take charge of their work, maybe not be so micromanaged, right? And many people with decision latitude are often in their job position for a while. So I kind of thought or predicted or hypothesized that work-life balance would coordinate with decision latitude, but it didn't. The things like supervisor support, coworker support, they did, right? That's not shocking. And then things like stress, well-being, quality of life, all correlated with work-life balance, also no surprise. However, decision latitude did correlate with the level of caregiver burden, meaning if somebody had more job control, they actually had a less sensation of or sense of caregiver burden. And here's the visual data of the integration aim, right? And now I had mentioned that all those barriers, right? And all those facilitators were affecting work-life balance. And then out of all those facilitators, it's decision latitude, that job control, that directly correlates with a person's sense of caregiver burden. At least this was the finding in the 40 people that I studied. And then work-life balance is bidirectional with quality of life, stress, and well-being. Now, this is all well and good, and it's a very interesting finding. However, the solution to the problem, right, the fact that, we have caregivers who, right, they're involved in supporting the care of others at home. They may not always have high decision latitude, right? It depends on your work. And a person might not have good job control. Maybe this is a new job that a person just began. But if we start to think about what can be done to help, right, to help the caregiver kind of reach toward good well-being and health promotion themselves, right, that they're not overstressed, that they're not, overburdened, that they're not feeling strained. When you look at this image, and this is actually a revision of the work-life conflict framework that was originally done by two researchers from the 1980s. My mentor, suggested let's start adding the boxes. And so, we looked at the alignment of worker wellness programs that maybe could be better aligned to help caregiver needs. work accommodation schedule changes. And then on the other side, as you can see on the right, what are all those resources to help and support the primary caregiver? And then how do you get that caregiver respite? Which I'm going to talk a little bit more about suggestions in about 2 slides down. So to give you the big picture of the kind of conclusion of the study, right, there were limitations. Of course, this is a very small study. We really need a larger population so that we can better understand things like, how involved family members of those with dystonia are, the more details of, the types of role they play. And again, this was a predominantly Parkinson's group, right, with sub-findings. But wouldn't it be interesting if we kind of dissect further the different types of dystonia? And again, what are family caregivers doing? What are some of their needs if they have to have maybe more information, better access, and so on? And then finally, of course, there's the Policy Investigation of Family Medical Leave Act. Further investigation is needed, right? Chronic illness may result in more family caregivers needing better supportive measures for work and life balance. When we think about chronic conditions, this is not like a knee surgery, where in about 6 to 8 weeks, a person is going to be back on their feet and 100% better, right? Like nothing happened. But chronic conditions need the support of another person, and that support, it may fluctuate. There may be better days, and there may be days where the person doing the caregiving may legitimately need time off. And of course, the hope is that they're able to attain that. So now let's segue into the discussion, right? The real questions, right? That, finally, when I looked at my study findings and when I really thought about all the clinic examples that I experienced, over the years, I find that really discovering the routines, the detailed routines of both caregivers and those with dystonia is part of the answer in that caregiver wellness. And the photo that I included here is of these 2 ducks. So I routinely walk down toward the clinic from where I live. And, I'm in New York City. It's busy, it's loud, there's a lot of concrete, there's not much greenery. But for the last several years, every year around March, these 2 ducks show up, and they like temporarily reside by a fountain that's in front of a very large residential building. And I can't help but reflect. I think about these ducks and I think about their routines, right? And kind of how remarkable, right? Every year, same time, same place. And so I kind of, for me at least, I think about that analogy, right? So, what time do you wake up? What time does the person you're involved with taking care of wake up? What time are the meals? What time is exercise? Is there time for exercise? Is there time for reflection, meditation, the de-stressing activities like yoga, or, things that a person can do and feel good doing? And then, of course, is there time for social support, right? The idea that, we're not just running around and working and doing the busy things in life, right? But that there's time to, step out of that and reconnect, with people who, we can find joy with. And so I think, again, if you are, and this, again, this kind of goes for both parties, right? If you are somehow a family caregiver that's involved, I think it's important to sort of sit down and think about these things. And, sometimes it's not easy to do it by yourself. Sometimes it's good to like sit down with someone else, even a professional, right? Because if we think about what's supposed to happen during a neurological visit, ideally, right, we want to know what are the gaps in a person's life, right? Are they exercising? Are they eating? Are they really doing all those things? And then if there's the gap, right, how do we fix it? And so to segue into this slide, which I think, probably inevitably to spend the most time on, and then, after the end of this program, I kind of almost hope to hear from some of you who are listening tonight. If you have some suggestions, some things that work for you. So, again, kind of top down. Number one, right, getting to know your team. Certainly a neurological condition, any neurological condition is not meant to be dealt with alone. And of course, it depends, where you live. There are some places that have numerous centers, practically in walking distance. I will say that, we have that here in New York, right? There's kind of one hospital in walking distance from the other. And there's options, there's varieties, as opposed to maybe somebody who lives miles away and you have to drive, or, maybe you have to go to another state for support. But thankfully, in today's modern world, right, we have technology and we have telehealth, and there is just generally more information available. And more facilities are offering, one thing that came out of the pandemic is the idea of remote visits, as well as programs like these, right? Once upon a time, we were just meeting in person, and now we have the opportunity to share ideas. So either which way, if you can go as a caregiver to the visit, right? If the person that you're helping, you're supporting, will allow you to join them, I think that's number one. That's the start. This way, you can also be there for that conversation. And it is my hope that as the time goes on, caregivers become less of that, that person sitting in the corner of the exam room, but rather a person who's part of the dialogue. And by getting to know your team, seeing, what do they say? What are the thoughts? What are the ideas? Are the injections working? Is the medication working? And then to talk about those previous, just jumping back for a moment, the routine. Is there a real problem in the routine that somebody maybe isn't really coping well? Next, and one coincides with the other here, right? So we want to really seek out resources. And again, to kind of be very broad, because there's always a case by case assessment. Everybody's different. We have different needs. Physical therapy is a big one. And I think in some cases it gets undermined. We know that when there are muscle spasms and muscle contractions or pain, it does have to be dealt with very carefully. And though there are so many physical therapists out there, not everybody is well versed in neurological conditions. And so I would emphasize that a person really spends time making sure, right, and that the relationship with the physical therapist is good too. Because over the years, I've had a lot of people come back to me and said, I met this physical therapist and they were great, but for some reason, it seemed like they just didn't get it, right? So if that's the case, then we must seek greener pastures elsewhere, because otherwise the sort of therapeutic outcome will never happen. Next, very undervalued and sometimes missing from practices is the social worker, right? And just as a side note, we're very grateful because we recently have hired a new social worker in our practice, and I can see the difference already. That level of care, the opportunity to have somebody who can help focus on all those additional parts of life. And then, of course, right, no big surprise, right, that we have support groups. And I am a big, really a big proponent of support groups. I've been fortunate enough to be able to run them over the years, and different groups where we had, people, again, with different conditions, people post DBS surgery, the opportunity to find, others who are going through, have gone through, or may go through, a similar path. And again, it depends on your network. And again, where you are. There are, I would say, again, at least for our area here, places that have started slowly picking up and meeting in person again. Sometimes support groups even get tied with like exercise classes, or, it doesn't necessarily have to be just an online sit down. There are other variations. And I recently had a debate with another provider, from another practice, and we were talking about, is our support groups the answer for loneliness, right? Is it, and it may not be the full answer, because a person can still be sitting in a group and feel completely by themselves, right? But at least there's some connection, right? Some connection, witnessing what other people are doing. And while, I think everybody has to come to their own terms of, whether groups are for them or not. The caregiver groups that I have at least had the chance of either popping in on or leading myself, I've noticed that, again, there's just some sort of a therapeutic connection that happens. Plus, you get to hear ideas from other people, right? It's like sometimes the answers are not just in a clinic. Sometimes the answers go even beyond of what, maybe the physician or the nurse practitioner is trying to do. Sometimes you can get a suggestion, a tip, some way of dealing, even the sensory tricks, right? We know that dystonia can be so responsive to. And so if you hear the stories of others, it's like another way also of gathering information. So, that's like my third sort of pillar of the suggestions. And then finally, right, because, nobody's superhuman, right? We all have our strengths, we have our weaknesses. And, if you find yourself that you've gotten involved, you're helping, there's somebody relying on you. And again, whether, this is an adult or even as a caregiver of course, young children, right? Like I mentioned, a person can even be split between taking care of sort of multiple people in the household. It's really important to take a break, right? The idea of caregiver burden that was mentioned sort of throughout these slides, it's real, and majority of people, whether they like to admit it, may feel some sense of that, and that is correlating with stress, it's correlating with quality of life, and it just generally will correlate with one's overall well-being, right, and sense of wellness. And so the respite, that part, there isn't a full prescription for it, but it has to come in some form. And I think, having the chance even just to think about it, it's like, who can I ask for help? Who can I depend on? Is there a neighbor who can, lend me a hand? Is there a relative? And in some cases, maybe it's a volunteer, maybe it is a professional caregiver that sort of has to step in and take over for a little bit, so that you can also sort of regain some momentum in your life, right? The idea that if you give up everything just to either, focus on the help of someone else, that can definitely lead to not just from caregiver burden, but then towards something called burnout, and nobody wants to get there. There is a lot of literature about the concept that the person, right, let's say who has a condition, the state of their health will also correlate with the state of the health of the person who's taking care of them, right? Meaning when one person does better, the other person does better. Plus, if a caregiver is suffering from something, and again, like I said, we are vulnerable, we're human. It is unusual that a person doesn't go through life having some type of health challenge. Is that, right, if we at least try to push for that health promotion. And so I hope you can sort of, think about these things, think about, who's your team? Do you have the resources? Where are they? Who are they? Do you know them? And if you don't know them, can you get to know them, right? Support groups, even things like what we're doing tonight, I think can add a lot of value to, your day. And then the respite, right? How to get that extra support throughout your community. So I just wanted to say a special thanks, right, Dr. Harini Sarva, who has really kind of pushed me to get into research and to explore these topics, and my Weill Cornell colleagues who have been running really such a tight ship. Dr. Dixon, Victoria Dixon, is my mentor, and she was the one who said, what about work-life balance? How can we study this in the context of family caregivers? and Dr. Witkowski-Stimfel, Dr. Jason Fletcher, that's our wonderful statistician, and a big shout out to all the patients who participated in the family caregiver study. So thank you all for listening. I do look forward to any questions. And like I said, even any possible things that maybe worked for you as a caregiver, any of your own suggestions. So thank you very much.
Dr. Hellmers, thank you. That was fantastic. And I think your research points out that the relatively recent focus on the important role that caregivers have, as mentioned earlier in our healthcare system, and just the importance of them taking care of themselves, right? In addition to those they are the care partner for. So I really appreciate it. Having that research will help us move those policy issues forward. So that's incredibly important. So we have a number of questions. So one that we received in advance, this person describes the dystonia of their loved one as a series of losses, right? They have lost control over their ability to control. In this case, it was cervical dystonia. So their ability to hold their head the way they want to, which led to their not being able to work. They had to go out on disability. And it's really important for this person to maintain her independence. And the question comes from, I think, a spouse, although it wasn't stated as such. How do you help? How do I become a caregiver for someone who doesn't want me to help them because they want to maintain their independence? Any suggestions or thoughts on that?
Yeah, I very much appreciate that question because I do hear that. I hear that from others. It is not uncommon, right? Especially if you have a person who, right, it is strong and wants to be independent and isn't used to having others sort of, do things for them. It's hard and it's a process. There's no way to resolve that overnight. I think part of it is always having that soft reminder, I'm here for you. And the way I've witnessed it, right, it is a learning process for both parties, right, where the other person has to kind of accept where they're at, accept the changes, and inevitably also learn how to maybe lean on somebody a little bit, right? And again, it starts off slow. I would say, and again, this is why I mentioned even sometimes going to visits together, because it's like both people hear the story, they hear the sort of the medical aspect, right? And again, there's so much variability here because I always think that if a person may not be able to work, do their regular job, but there are other things, right? We can keep busy in various ways. Sometimes it just takes a while to figure that out. I even can think of people I know who retired, and even just by simply the sheer fact of retiring and that they're no longer working, suddenly it's like you have to figure out, well, what am I going to do with myself?
Right.
I think that having that conversation between both parties to say, well, how do you want to spend your time? What are the things that are also going to help you? So it's a lot of communication. And sometimes, like I said, it may be even helpful to get a third party, whether it be physician, nurse practitioner, social worker, and to start having that dialogue. And it's probably a bit of, like I said, the frustration. Maybe the person's feeling a bit of depression, right? Because when we feel so sad about, what we lose, I mean, that's real. But there comes a moment where there has to be some level of acceptance. And again, as long as you say, I'm there, I'm here for you. You call me a caregiver, a ghost caregiver. I think that was a definition that we talked about, right? Somebody who's like a caregiver, but we don't have to be super obvious about it. We just sort of follow in parallel, right? With any which way we can.
Right. Sort of the stealth kind of thing. Yeah. And in some ways, as you suggested, engaging someone to come to visit, to be that extra set of ears and eyes, almost as an advocate, helps to sort of pave the way into that role as a more traditional caregiver. So I think that's good advice. We had a question from somebody in our audience about, I've participated in brain injury groups, but they aren't affected by secondary dystonia. Would dystonia support groups be better? And how do I find one? I will answer that last part for, you can call our office, you can go to our website, we can get you connected with support groups. And if anybody is participating tonight and is interested in working with us to start a group, we have a wonderful program here at the DMRF to help you do that and support you through that process. But do you want to talk about sort of the important role of support groups? You mentioned this in your presentation, but I think specifically for this person, but also just generally the role that support groups have for both those who are affected and their caregivers.
Yes, absolutely. And I hear the challenge where, sometimes dystonia support groups they're not everywhere, right? We actually need more. And I like the idea of going to another group that, kind of is that umbrella, right? I think there can be some benefit there because again, you hear stories. It just becomes a little harder when perhaps the focus is on like another thing. I can think of the example as like we have a Parkinson's support group and we have a mixed crowd, mixed ages, mixed everything, in a sense that we don't have like a specific subgroup, it's a broad group. And there are some people who have what we call atypical Parkinson's, or they have, it's not Parkinson's, but it's like sort of in the family, and the definition of the condition is completely different. But those super rare conditions, they kind of don't know where to go. And it's almost like the more rare your condition is, the harder it is to find, these large groups that you could feel like you can super fully relate to. I would say a lot of the times, if the groups are well moderated, you could still at least learn about, okay, where are they getting their therapy? Where are they getting exercise, right? Those little clues that you can gauge from other people. And then, of course, if you can find that network, and if the inspiration is there, right, starting a group with 1, 2, 3 people, and then before you know it, the group grows. So,
right.
Yeah.
Yeah, and I would also say I encourage people to contact the DMRF office. We often can put people in touch with someone who may not be in your immediate geographic area, but who has a similar situation with their dystonia. And sometimes just talking to somebody who has the same sort of profile that you do can be really helpful. And just swapping coping mechanisms and those kinds of things can just be really, really helpful.
Yes, I will quickly add to that. If there is someone who volunteers to be an advocate, sometimes one-on-one is really the way to go, because that's you can ask questions. Sometimes even our medical facilities, we have a hard time like connecting people because there's HIPAA. You need to make sure both parties agree to be connected, but it does happen. So I would also inquire about even just a one-on-one. Can connect me with somebody who maybe would volunteer.
Yeah, good point. Yeah, and your center is always really good about that. So yeah, I think that's a really good point. We know many people with dystonia can be isolated. It's a rare disorder, as you said, and not many people have heard about it. And depending on the severity of their dystonia, they may be withdrawing. Either physically they're not able to participate in their social world as they once did, or as you mentioned, depression or anxiety prevents them from going out. The isolation can also affect their care partner or their caregiver as well. And you touched on this a little bit about respite and that kind of thing, but can you comment on the importance of the caregiver also being in tune to those feelings of isolation and what they should do about it?
Absolutely. So again, when the way we see this formation of isolation is usually a person starts to become a bit withdrawn, right? That maybe they have the symptoms, they don't feel great, or maybe they feel okay, but they're worried they're not going to feel great when they get there. And so rather than put themselves, in that position, rather just let's stay home. You know, and that's hard because, right, if let's say if it's a spouse, if it's a sibling, if it's somebody that you used to do these things together with, it's like a double loss, right? And sometimes there can turn into resentment or even anger, right? If you know, one person doesn't understand the other one, well, why don't you want to go? You know, that can actually spread, it can grow, and it can become really unpleasant across the board. And I've spoken to, you know, people over the years, whether they were spouses, couples, and again, it's some kind of compromise. It's like if you think about it, right, compromise is always the way to sort of like the path to getting to some sort of an agreement. In some instances, of course, this is where I was saying that if the caregiver has to step aside and say, you know what, I know this person's not doing well. I will let them rest, but I will do this because, well, I have to, right? We can't, you know, let there be one representative of the family attending an event so that it's not a total loss. And then maybe find a way to get that person to reconnect, or maybe have the person who maybe isn't feeling so well go for a little while, and then arrange for maybe they go home a little earlier and then that person stays. I think that becomes already a little bit more, right? So we're modifying the occasion, the event, you know, if we have to go home a little bit earlier, but at least not to miss out completely. It comes to mind, I was thinking back on a story of it was basically a spouse who said that, you know, they had weddings, there were graduations, and you know, they said that if the wife was saying that, she said, if I don't go, then I'm really doing a disservice to both of us in a sense, right? To say that we're supporting our family, we're there. And then, you know, she would bring back whatever she could, whether it be food, whether, you know, pictures, the story. But like I said, we all know life is short and life goes on, right? Whether we're sick or not, there are things. And I think just like before, it's the communication between the two, right? How can we make this happen? How can we accommodate? Um, and there are ways. It's just a matter of talking about it and not ignoring it.
Right, right. And I think to your point during your presentation, you know, loneliness. I mean, the Surgeon General issued a whole report on loneliness and how it's affecting people's health, and the importance for caregivers to really pay attention to their own health needs. So if it means, as you said, communicating and working out a compromise so that that person can have that kind of social exposure and help them, they are in turn helping their loved one who is dealing themselves with dystonia or whatever other chronic disease there might be. Would you also just talk a little bit about the importance for caregivers to be educated and stay abreast of things that are happening as it relates to new treatments or dystonia research? Is that an important factor, do you think?
I do see that it is. And again, this is sort of like a decade of just my own experiences to see how much has changed. And there's something about, you know, staying informed, staying on top of things, also knowing, right, knowing that there's a lot of research on the horizon. Even if we think about how much deep brain stimulation has changed, how, you know, we see the technology, and with that comes a lot of hope, right? Knowing that, yes, we have a chronic condition. Yes, the situation is hard. You know, yes, there's going to be a lot of battles to go through, but there are potential changes, right? And with the way, I even see now with the way science has become more complicated, and I'm pretty impressed with some people who they come into clinic for follow-up and they're like pulling out articles to show me and say, oh, look, I read this, you know, or I heard about this. And I think that's great. That's empowerment, right? Rather than just ignoring, just letting it go, just sort of like, all right, we'll just wait around and see what happens. So the more knowledge, that's key. And we were doing a brain health talk not that long ago, and a lot of the information was even maybe repetitive, right? You know, exercise, sleep, make sure you eat well, etc. Right? But somebody commented, said, "Wow, you know, it kind of like it's like if you hear it more and more and more, eventually it connects, right? You start to understand." And I think that's also the way with dystonia, because regardless of if it's secondary, if it's a primary diagnosis, it's complicated. And I
Yeah.
think very few people could actually like spit back out and describe what they have. Even patients, they can describe symptoms, but it's hard to really understand, like, why are these things happening? Same thing for the caregiver. So it's like the more you know, the more you tune in, you become that very knowledgeable patient and that very knowledgeable caregiver, and that's really powerful.
Yeah. Information, what is it? Knowledge is power kind of
Knowledge is
thing. So
power. Yeah.
yeah, yeah,
Yeah, it's a different, like I said, it's a completely different clinic visit, right? As opposed
right.
to coming in like, what's going on, right? This way you say, all right, these are my medications, this is what I'm taking, this is what's working, this is what's not working. And then asking, well, how is this supposed to work, right? So the
Mhm.
more you learn about it, I think we also come to better conclusions for treatment that way. I do see that with Botox in particular, and I'm actually very fortunate. I have kind of a nice role where I don't inject, right? That's not my position in the practice, but I do the go-between visits, right? So
Mhm.
after 6 weeks, somebody gets, injected for their cervical dystonia or whatever else. And then we talk about it. We ask, did it work? Did it not work? How do you feel? Do you have side effects? What happened this time compared to last time? And I know not every practice does that, but I think there's still ways that, a person can write it down, keep track, say,
Mhm.
I got this amount, how come it worked last time? Why didn't it work this time? And then you go in there and you have that dialogue, right?
Mhm.
Before you get injected next time, you come, ready with a list. And
Right.
that way the chances of it becoming more successful is higher.
Right. And having that caregiver present to sort of be that reminder, because I think we all tend to get a little flummoxed when the doctor or the nurse practitioner comes into the room and it's sort of like, oh, I completely forgot what I was going to ask you or tell you. And you have somebody who's a little more objective to remind you of what you wanted to say. As you were talking about information and knowledge and staying abreast of things, I'm reminded of two situations, sort of the opposite, where the person affected by dystonia was really masking their symptoms, really battling them in front of, in both of these cases, it was a spouse for whatever reason. And in one instance, it was the husband. Both of the patients were women, but in one case, the husband attended a meeting, an educational meeting that the foundation sponsored. In the other situation, the husband actually got the Dystonia Dialogue, the magazine that the DMRF puts out. And they both were introduced to dystonia sort of generally in a way that they hadn't been just through their lens of their own family member's situation. And I remember they both told me that they apologized to their wives, thinking that this was sort of no big deal. And then when they really got informed and recognized the really how debilitating dystonia can be, they felt terrible that they hadn't been more supportive. And it was really sort of a turning point that the patients themselves had sort of wanted to be on their own and be independent and again mask their symptoms. But once that information was shared and their loved ones became better informed, they were allowed to be care partners, right? So I think sometimes information can help you engage someone even when you think you don't need somebody, in addition to being a good care provider long term, if that makes sense.
Yeah, yeah, and then it's like, as you had said, that's an eye opener, right? That they never thought about it in that context. And again, it's, depending on the type of dystonia, sometimes it's not visible at all,
Right,
right? Person can be suffering so much.
right. Yeah, it's really true. It's really true. And as you said, communication is just really so important. Communication with each other, communication with your healthcare provider. Just being open and communicating what your needs are, communicating what's worked, what hasn't worked, that kind of thing can lead to better outcomes all around. So yeah. Um, I think we have one last question. Um, this is maybe a suggestion. I think it's important for a caregiver to be honest with the dystonia person. Let them know that they're going to have bad days, but good days as well, to tell them that dystonia is there. Can be lighter because of the help that's out there. So I think that's good advice. Yeah, thank you, Don, for that. So
That is excellent advice, right? That honesty, right? And you meet each other where you're at.
right,
Um,
right.
I always say I like to err on the side of optimism, but we also have to be realistic, right? And
Right.
that honesty comes in.
Yeah,
And that,
it's true. It's true. Well, this has been wonderful. Thank you so much for sharing your research with us and giving us the benefit of your experience. And I know I know everyone who watches this will benefit from that, both caregivers and those who are battling their dystonia. So thank you so much for this and for the work that you do every day. We really are grateful to you.
well, thank you for having me. It was a pleasure to be here.
Thank you. And thanks everyone for tuning in. Until next time, thanks everyone. Bye-bye.
Bye, everybody.